questions can come from a university point of view. They might ask a history on chronic inflammation, most likely tuberculosis, and ask you to explain the granuloma formation, different types of granuloma. That could be a long answer question. They might give you a simple example of a acute inflammation. For example, even pneumonia. I can ask a simple example of an acute inflammation and ask to explain what's going to be there happen in acute inflammation. That also can come in the exam. Inflammatory mediators per se, any of them, could it be in prostaglandins, arachidonic acid, chemokines, can come in a short notes, right? Very unlikely for them to ask inflammatory mediators in a long answer because it is not correlating with any clinical information, right? Or they should push themselves to have a acute inflammation and say what are the mediators which are going to help in the acute inflammatory process, right? Most likely it will be in short answer, right? Okay, wound healing, yes, very likely in a short answer, especially the factors which affect wound healing, the keloid, the hypertrophic scar, all those things can also come, right? Good afternoon, Shubhajit. Good afternoon. Yes, 4 p.m. right? Okay, so let's quickly revise what all we need to know about inflammation and wound healing in the next 1.5 hours. First, if there's a short note asked on the steps of acute inflammation, I'm going to quickly revise the short notes. If it is in a long, lengthy note or an essay question also, we can add an extra point and make it an essay question as well, right? So first, short notes of acute inflammation. The first thing is going to be stimulus. You can write about any stimulus, whatever comes to your mind, as simple as a mosquito bite or a tiny falling down or a scratch, wound, trauma, anything can come under acute inflammation, right? So first, I need a definition of an acute inflammation. Acute inflammation is an inflammatory process which is going to happen within a span of hours to maximum days, mostly hours only, right? Minutes to hours. And the cell of acute inflammation, which you have to say, it's going to be neutrophils. But please remember, if it's in a viva, I also want you to write eosinophils as well. Tell eosinophils as well, because eosinophil is a cell of acute inflammation. If the etiology is allergic mediators, otherwise it's going to be primarily neutrophils only, right? Then if you say the hallmark of acute inflammation, these three are the first things I want to be there in an exam paper whenever I'm talking about acute inflammation, is increased vascular permeability. It's not just vasodilatation. Vasodilatation will be there, but increased vascular permeability is much more solid for me because without vasodilatation, vascular permeability will not happen. Just vasodilation alone will not be enough. Vascular permeability is required, right? And if you want to write, you can also write the next line, the cardinal features of acute inflammation. Can anyone tell me the cardinal 5 important things for acute inflammation or inflammation per se? Mostly predominantly for acute inflammation. Yeah, rubor, calor, tumor, dolor, and functionalacia or loss of function, right? You'll be redness, you'll have warmth, you'll have pain, you'll have swelling, right? Tumor, okay? Tumor means just swelling, that's all, right? And you'll have loss of function or functionalacia. That's the last cardinal sign of most of the acute inflammation, right? That's done. Now we have to read about the steps. Come on, guys. Since it's revision, I want you guys to actively involve there. So, Subhajit, anyone who's online. So, tell me what comes to your mind when you talk about steps. There are 2 things here for me. In detail, you must read about cellular phase, yes. Vascular phase, yes. There are multiple subtypes of vascular phase also. In a short note, I need not write much about that. Whenever there's stimulus, I am going to have cellular and vascular phase happening together, and obviously the cell is going to come outside. The focus emphasis is going to be more on the cellular phase and not the vascular phase, right? So, when say acute inflammation, maybe draw a diagram like this and say that there is a stimulus here. Because of the stimulus, the goal is for the cell to come outside and destroy it. In this process, we can divide the initial thing into a vascular phase and a cellular phase. Vascular phase, simply you can write, most likely it's vasodilation. That's the vascular phase which I'm talking about, which is primarily mediated by histamine. That's more than enough. Second, I'll have endothelial gaps. Instead of writing increased vascular permeability, no, use the term endothelial gaps because that's much comfortable, right? Endothelial gap formation. If you write endothelial gap formation, if it's a short note again, just write the possibilities. Could be mediated by same histamine. If it's an immediate and a transient one, could be mediated by reversible endothelial damage, right? Perfect. Could be mediated by UV rays, radiation. Could be mediated by trauma, right, which is irreversible injury, right? Could be mediated by trauma, which is an irreversible endothelial damage. Based on the severity, whatever is going to happen will happen, right? The histamine might be like a, if you remember our classes, a hot water spill, right? reversible endothelial damage. I have a different example, a cooking related injury, little bit longer time. UV rays will cause a radiation induced damage, or in cancer radiotherapy. Irreversible damage, trauma, burns, anything severe will cause irreversible damage, right? These are the vascular events. When you say cellular events, it's going to talk about the rolling adhesion diapedesis. If you are good in presenting things, put a table and write what is involved and what will happen. Just one table, draw like this, the cellular events of acute inflammation, rolling, right? Adhesion, diapedesis, if possible, chemotaxis alone. You can write in a single table. If you're not that great in putting a table, write point by point. That also is okay for me. Because table will give an easy screenshot, will not make the examiner worry for long. Where is it? They shouldn't search. If they start searching for the answer, I'm not grabbing the attention properly, right? So in cellular stage of acute inflammation, I have 4 steps. 1, rolling, adhesion, right? Diapedesis. The chemotaxis also is going to be here only. Fine, then chemotaxis, because that also the cell, it's predominantly mediated by the WBC's response, right? WBC is moving outside to the site of inflammation, right? So let's start. What molecules will help in rolling process? Anyone? Come on, these are simple questions. Rolling is mediated by 2 important factors. One is your selectin molecules. Where will be selectin? Endothelium or WBC? It's a template. Every process, I have 1 molecule in endothelium, 1 molecule in WBC. Based on that, it goes. That's all. In rolling, I have endothelium, I have selectin, and Cellular X is going to be on the WBC, right? In this, I have E-selectin, P-selectin, and L-selectin. L-selectin is not that much useful with respect to inflammation, right? Perfect. So a P-selectin will always be along with my von Willebrand factor in a place called as an Weibel Palade bodies. It will be along with von Willebrand factor in Weibel Palade bodies. That is going to be in the endothelium only, right? And E-selectin, E stands for endothelial selectin, right? It's simple. These are the molecules there. So once acute inflammation hits, so if you want, draw a diagram. Normal endothelium and have the selectin molecules inside them. These dots are the selectin molecules. Whenever I have your inflammation, interleukin 8 or any inflammatory mediators, I need chemokines. Only when the mediators are going to come, by default, the selectin molecules will come to the surface. The surface expression of selectin, and you have the WBC binding to it. WBC will have the Cellular X receptor. So once I have the Cellular X receptor on the surface of WBC, this diagram explains everything. Normally it's inactive after interleukin 8 or after the mediators of inflammation. It becomes active, it binds to Cellular X. And you can write that this bond here is a weak bond. Since a weak bond, it rolls on the endothelium. Okay, the blood supply pushes and it kind of rolls on the endothelium. That's simple about your first step of the inflammation, which is rolling. After rolling, what happens? It has to stop at some point. Adhesion. The first and most important thing is adhesion actually happens at the site of endothelial gap. This is important to mention this. These blood vessels will have gaps in them. Only at the site of the endothelial gap, yes, I'll have adhesion there. It cannot stop anywhere. It will stop exactly there. Then only it can escape there. In addition, I have 2 molecules again. In WBC, I have integrins. If it's a long answer, write beta 1 integrin, beta integrin. Otherwise, just write integrin. And endothelium, I have CAMs, cell adhesion molecules. The same way, these are also, initially what happens? My CAMs are also here. Initially what happens is integrin is there in the WBC. Draw something like this, like covered. Integrin normally will be in low affinity state. When I say low affinity state, it's not ready to bind that much to a cell adhesion molecule. The same interleukins due to inflammation, I can say interleukin 1, TNF, interleukin 7, whatever it is, 8. Whenever the inflammatory mediators are more, what happens? This will change the WBC's integrin into a high affinity state. I'll have CAMs here, cell adhesion molecules, and now the integrin becomes a little bit stronger, high affinity state. the affinity of integrin changes here. In rolling, the selectin becomes expressive. So primarily the interleukins are going to attack the selectin and your integrins only, fine. So it binds, and this binds a very strong covalent bond. Okay, so once a strong covalent bond, it does not move, it stays, it adheres. That's all. Beta 1, beta 2 integrin, LFA, MAC are just extra pointers. If you are clear in writing what is happening inside the body, that should be more than enough for me, right? So once the addition is over, the next step is to get outside. And the most important thing, when you talk about diapedesis, to grab the attention of the examiner, write that diapedesis is equivalent to transmigration of WBC across endothelium. That's my definition. Okay, it's nothing but transmigration across the endothelium. The moment it migrates across the endothelium, what will happen? It has to destroy the basement membrane. Then comes, it's a two-step process. Generally, we think that diabetes is a one-step process. The two-step process, one, with the help of your PECAM1, the WBC can escape the endothelium. It will just bind like any adhesion molecule. It will bind and it will pull and throw it away. So here, if you want to draw a diagram, draw a very thick basement membrane, because it's important for us to understand that the basement membrane is most important here, and it's going to be extremely thick basement membrane, right? So the basement membrane is thick, and on top of that, what I have an endothelium which is given way. Endothelium which is given way, right? So here, my WBC here is going to be squeezed outside with the help of these PCAM molecules, PCAM1, right? So the PECAM1 will help me to squeeze and get outside. I cannot draw a animation in a paper, right? So just draw them and make the WBC deformed. And the next step is this. The second step here is the neutrophils or the WBC per se will release one of its granule content is going to release non-specific collagenases. That's very, very important. I'll have non-specific collagenases. This non-specific collagenase is must for me to put holes. This is my basement membrane. Here it kind of makes gaps, right? So in this gaps in the basement membrane, because of the non-specific collagenases, it can easily come outside. It will move outside and I'll have a superb normal neutrophil outside. This is transmigration or diapedesis. It's a two-step process. Please don't forget. One is PECAM1 with the help of your PECAM1 or CD31. It's going outside, and the non-specific collagenases is providing me a little bit of gaps in my basement membrane through which it escapes outside. The moment it comes outside, the next step is chemotaxis. 2 pointers, unidirectional and actin polymerization. These are chemical signals via which it will reach the site of infection, whatever I want to remove, right? So how does actin polymerization help? Normally, inside the WBC, let's put a nucleus in the corner. I have G-actin. So due to actin polymerization, the G-actin becomes F-actin. F-actin is your filamentous actin, right? That's pseudopod. This is how pseudopods are formed. So once you have pseudopods, automatically it will break again and it will move to the new location. Again, it will form G-actin. The same thing continues, G-actin, F-actin, G-actin, F-actin, right? So that's what we mean by actin polymerization. Who pulls them? That's where the chemotactic mediators come into play, right? Simple things to remember, but I want two classifications, the endogenicity and exogenicity. Endogenous chemotactic factors, we have your interleukin 8, we have your C5a, we have your leukotriene B4. These are basic things for me to write. If you want to add few more chemokines, great. There's nothing wrong in that. Every chemokine, what you know, CXC, CX3C, all of them are chemotactic factors. Rantis is a chemotactic factor. But these are 3 basic low-level things. At least this mentioned, and also there's a group of mediators called as chemokines. They're also chemotactic factors. Exogenous, anything from outside. Lipopolysaccharide of the cell wall, right? Any virulence factor, you can write flagellar antigen, flagellants, anything, right? Anything which is from the bacteria or the virus or the fungi can be a chemotactic factor, which is exogenous, right? You know endogenous, we know exogenous. Now, the next step is phagolysosome formation. The WBC came here with lots of struggle, and I had a bacteria here. What it does, this is going to engulf the bacteria, right? It'll engulf the bacteria. Once it forms, engulfs it completely, it forms a tiny area with the bacteria. Inside the cell, we call it a phagosome. And obviously phagosome will unite with one more important organelle with me, which is lysosome. And in the phagolysosome, what happens here is the phagolysosome complex, which is going to have both the enzymes and the bacteria, which happens inside the WBC. This is where the battle happens. We have phagolysosome, and inside the phagolysosome, you're going to have the respiratory burst. Respiratory burst, or the oxygen dependent mechanism, is the most important and the most effective way to kill a bacteria, right? This happens inside. So once I have the phagolysosome complex there, what's going to happen next? I'm going to more focus only on the respiratory mechanism, and non-oxygen dependent mechanisms are just the neutrophilic granules. Some random neutrophilic granules, lactoferrin, antibiotic capacity can definitely destroy the bacteria, right? So how do I kill the microbe? The main mechanism is oxygen dependent and is respiratory burst. Fine, it's always oxygen dependent, which is my main mechanism. Once I have that, with the help of the most important enzyme, these enzymes and these pathways are must for me. NADPH oxidase produces O2 minus, which is superoxide. The enzyme superoxide dismutase produces H2O2. Then I have two pathways. One is based on major basic protein and iodine. The other one is based on myeloperoxidase and chlorine. So I produce HOCl minus and HOI minus. This is the most effective bactericidal. It will kill the bacteria for sure. This is against parasites. This will kill the parasites. This entire process, we call it halogenation. The process by which I'm using halogens of chlorine, iodine to destroy them, we call it a halogenation. And this happens primarily in neutrophils, which is the cell of acute inflammation. And this happens in eosinophils, which can also be a cell of acute inflammation, right? Done. Once I have the bactericidal molecule, automatically I'll be able to completely eliminate and destroy the bacteria. Once that is done, if it is successful, okay, if it is successful, then I have an outcome. If it's successful, there are two options. You will be terminating the inflammation. If I'm not able to destroy, if it's not successful, right? Let's say successful, I have this problem. If it is not successful, okay? If the inflammation is not successful, if the organism, your neutrophil is not able to destroy it within 24 hours, 24 hours is time. I have to destroy the bacteria within 24 hours, right? So beyond that, more than 24 hours, the neutrophils will be replaced by macrophages, and it will be going towards chronicity, okay? And we'll be trying to eliminate the organism. That's what happens in acute inflammation. A simple flow on acute inflammation. We'll just quickly go back through it once again so that we'll understand it. Only one thing is left, which is termination. If there's a termination of inflammation, what all happens? Again, this is mediated by macrophage. But the macrophage which mediates termination of inflammation is M2 subtype of activated macrophage, which secretes interleukin 10, which secretes TGF beta, perfect anti-inflammatory cytokines. These are all anti-inflammatory. At the same time, they also involved in the wound healing process. And one more guy, which is arachidonic acid derivatives, resolvins, lipoxins, right? Lipoxins and arachidonic acid derivative, which also help in anti-inflammatory so that they can terminate inflammation. We started with something which we have to finish by default, right? Okay, let's go back once again to quickly go through whatever you require. Simple note on acute inflammation. Give a definition if required in your own words, but those definitions should have these points. Very short-lived, neutrophil being the primary cell of acute inflammation, and vascular permeability increased is the hallmark of acute inflammation. If required, write about the cardinal signs and draw a diagram and say there are two phases. Vascular phase is just vasodilatation, vascular permeability. Vasodilatation might be due to histamine. Vascular permeability based on the stimulus, it might differ. Then cellular phase, we had rolling, adhesion, diapedesis, chemotaxis. Rolling, we have your WBC selectin and your cellular access. Adhesion, we have your integrin and CAMs. And your diapedesis, we have two steps. One is PCAM, the other one is type 4 collagenases, non-specific. Most of them miss them. Please don't miss them, right? Then chemotaxis, unidirectional towards the direction of flow. These are the chemotactic mediators. Mention them. Endogenous, exogenous grouping is required. Phagocytosis happens, and then the final formula of respiratory burst. After that, within 24 hours, if I'm able to remove, I'll terminate the inflammation. If not, I'll replace them with macrophages, which completely will take care of it from there, right? That's about acute inflammation. Okay, now let's go to chronic. What do you think will happen with chronic inflammation, right? If acute inflammation is there, obviously we have to a little bit learn about chronic inflammation. Whenever we read about chronic inflammation, we'll also definitely look at the granuloma formation, because the microscopic finding what we see is granuloma, right? So chronic inflammation, everything, like I said, will have a definition, right? Chronic inflammation also has a definition. So chronic inflammation is a response to prolonged duration, months or weeks, in which inflammation, tissue destruction and healing is the most important hallmark, right? Okay, so per se, chronic inflammation, two few things which I want you to include in the definition. Definition has to be in your own word. That's how it is. The response is delayed. The response is prolonged, not delayed, it's prolonged for weeks, even months. Days also can be put in there, but weeks to months it's prolonged, right? With during the inflammation, tissue injury and healing by fibrosis is the hallmark, right? So the inflammation's hallmark here is primarily characteristic feature is CF is characteristic feature, tissue destruction or tissue injury, and it will by default heal by fibrosis. And what's the cell of chronic inflammation? For me, the cell of chronic inflammation is undoubtedly macrophage. Macrophage is cell of chronic inflammation? Yes. Lymphocytes also to some extent. If it's primarily autoimmune disorder or virus, yes, I'll think of a lymphocyte. Otherwise, it's by default your macrophage. Fine. Medico, not something which I can answer over the text, but I feel if you want to do it, might be worth it. Maybe a prolonged journey. That's it. Fine. But I would say go back to the books, not online. Okay. Now, let's go to what happens in chronic inflammation, the pathogenesis and the prototype of tuberculosis. When you look at the pathogenesis or prototype of tuberculosis, this I can write for any chronic inflammation, but change the antigen alone. That's all, right? Let's say you have draw diagrams rather than writing. It's much easy to explain in a flow chart or a diagrammatic manner than just writing it. Fine. I have an antigen presenting cell which presented TB antigen to my CD4. Okay. This is where it starts with, right? My macrophage is not able to eliminate it. That's why it's presenting here, right? So why it's presenting? Because macrophages can't eliminate TB, can't digest TB. TB can grow inside the macrophage and it can destroy it, right? So macrophage is struggling, so it's not able to digest. So automatically it will present to my CD4 cell, right? This CD4 cell becomes your Th1 subtype. This Th1 subtype is going to release one of the most important guy, interferon gamma. This interferon gamma will convert my normal macrophage into activated macrophages. Which subtype of activation? This activated macrophages, M1 subtype. This is very, very important. Classical activated macrophage or an M1 subtype. This classical activated macrophage or an M1 subtype is going to release because the function changes. The function here is secretion. It's not phagocytosis anymore, it's secretion. The moment they start to secrete, what all they will secrete? I'll have more amount of reactive oxygen species, more amount of nitric oxide. The goal here is to try to kill the organism. I'm equipping the normal macrophage with more ammunition, more power to kill it. Next, not just that, it will also secrete interleukin 1, 2 and interleukin 12. How do they help? This interleukin 1, 2 will attract more or produce more lymphocytes or more T cells from the blood, or it's going to produce by default, right? Then interleukin 12 will convert a T cell to Th1 subtype. So now when the Th1 subtype once comes, if you're writing in a proper sheet of paper, you can automatically say that that's going to go back here. So it's kind of like a vicious cycle. It keeps on going again and again in the same direction. That's what is going to cause the granuloma, right? So this entire thing, at the end of it, I will have a structure that is granuloma. Granuloma is defined as a tiny structure with lots and lots of epithelioid cells which are covered with reactants species, and your giant cells, which is nothing but a combination of epithelioid cells trying to kill the offending agent. That's what granuloma is, right? It's nothing but it's a primarily a collection of epithelioid cells in the center, okay, and yes, they might have giant cells. Giant cells is going to be plus or minus. Short answer, just write plus or minus. Long answer, right? Just giant cells, nothing but a union of epithelioid macrophages. Multiple nucleus is just a union of it, right? Then surrounded by lymphocytes. The goal is simple. The goal is to kill the offending organism. The goal is simple, to kill the tuberculosis. So the outcome of the granuloma, I'm going to divide into two outcomes. Write those two outcomes. If you can draw, great. Need not be super expert in drawing. Center pink color, call it necrosis. Okay. Put a few spindle-shaped cells, elongated cells with a nucleus there in the corner. Call it epithelioid cells. Make sure you draw a giant cell. Giant cell is a bit easy to draw, right? Call it there, right? And surrounding dots. Nothing but dots. These are my lymphocytes. So something with the center pink color, necrosis, we call it necrotizing granuloma. Something without the center pink color, we call it non-necrotizing granuloma or non-caseating granuloma. Fine, that's it. I'm necrotizing, I'm non-necrotizing. The moment we lead to necrotizing, non-necrotizing, next should be the table. What all would be the causes of necrotizing or non-necrotizing, right? You can write below the diagram only what you have drawn, or put a table and draw it. The way I have taught you to remember is necrotizing is cell death which kills, but don't write that in the exam. That is just for us to understand. Necrotizing granuloma means it has the ability to kill the organism. That's all, which means infectious cause. TB is the first cause. Pure neuritic leprosy is the second cause. Most of the bacterial or infectious granuloma will be necrotizing, right? Histoplasmosis to fungal and coccidiomycosis. Fungal granulomas, bacterial granulomas can be that. Non-necrotizing, again, I am not able to kill, but first thing, always write TB. TB can be both necrotizing and non-necrotizing based on the immune system of the patient. Rest everything, non-infectious cause. It could be as simple as your foreign body granuloma. Foreign body, any foreign body can happen. Like suture is one of the simplest example, right? Then you have your occupational lung disease. Your silicosis will have, right? Then we have Hodgkin's lymphoma. Again, it's not an infectious cause. It's a neoplasm, right? Crohn's disease. It's a non-infectious cause. It's an autoimmune disorder. Autoimmune inflammatory disorder, right? Last but not least, sarcoidosis. Okay? All this will be there. All these are cause of non-necrotizing or non-caseating granulomas, right? So you know non-necrotizing, necrotizing granulomas. Once you're done with that, few exceptions or few elaboration of giant cells, because giant cells will easily take half a page of it for you to draw and explain. That will attract the examiner's attention as well, right? So what are giant cells? Based on the nuclear arrangement, we come to a probable diagnosis. That's the goal. I have few nuclear arrangement. Based on that, I can call most likely this a U-shaped or a horseshoe-shaped arrangement of the nuclei. We call it Langhans type of giant cell, and is most likely seen in tuberculosis. Circular or wreath-like. This nucleus is arranged in the form of circle like this. This is Langhans giant cell. We call this two-tone giant cell. And two-tone giant cell is a classical finding seen in xanthoma. If you're drawing xanthoma's image, the two-tone giant cell, make sure you draw clear areas around representing lipid. Xanthoma is nothing but collection of lipid, right? So that also can be there, fine. Next, haphazardly arranged, right? We call it foreign body giant cell. And foreign body giant cell could be anything, could be a suture material, could be a nail, could be a thorn, anything. I don't have a name for it, just foreign body giant cell, where the nucleus does not have a shape, just randomly arranged, right? Perfect. Now, few other things. I have three more separate or unique granulomas. Stellate, based on the irregularity, you can call it star-shaped or just irregular granuloma. Cat scratch disease, can have stellate granulomas. Lymphogranuloma venerum can have stellate granulomas. Donut shaped, again based on shape. In two places, it's more common, liver and bone marrow. Okay, both of them have a fat in the center, which looks like or makes them look like a donut, right? Then you see them as Q fever. That's one condition. The other one is allopurinol toxicity. Fine. Allopurinol toxicity, you have that. That's the second one, donut shaped granuloma. Last but not least, microgranuloma. When do I call that? Less than 25 epithelioid cells. I can call it a microgranuloma, and I see them primarily in toxoplasmosis. The most important thing in microgranuloma is there should be no giant cells. The moment I start having giant cells, I know that it's not a microgranuloma anymore. Fine. Okay, these are few examples of granulomas. We can easily structure any question on chronic inflammation like this, right? I'll just go up once again, quickly see through what we saw. Definition should have few keywords. A prolonged persistent inflammation, one, which always ends up in having tissue injury, tissue damage and healing by fibrosis. That's second, where the primary factor of inflammatory cell is macrophages. These are three simple things required. Prototype is tuberculosis. Macrophage can't destroy TB, so they presented to CD4. CD4 became TH1. TH1 gave you interferon gamma. With that, it became M1 activated macrophage, whose function is secretion, secreted more power reactoxin species nitric oxide to kill the bacteria, secreted interleukins to attract more T cells and convert them into TH1 subtype so that the entire process can go on and keep on going in a vicious cycle. Ends up in having a granuloma, which is nothing but a collection of epithelioid cells clustered around the organism, which may or may not form a giant cell surrounded by lymphocytes with the sole focus of destroying the bacteria. Successful will have necrosis, otherwise no necrosis. And then we gave the examples of necrotizing, non-necrotizing. Only one basic thing: infectious, necrotizing. TB can be non-necrotizing also. Rest every non-necrotizing is non-infectious. Fine. Giant cells, we know subtype, we know special granulomas as well. More than enough for your granuloma formation. Fine. Now the third one. Write a short note on systemic response to inflammation. See, systemic response is required because if I have to ask a question, my major concern is about systemic response. If you are not able to know the your diapedesis, your rolling, your adhesion, it really doesn't matter for me. But systemic response is something which you will see in everyday patient day in and day out. If I'm not able to understand the systemic response, or I'm not able to talk about acute phase reactants, I cannot diagnose inflammation. That's required, right? So what is systemic response is the first question. Okay. Systemic response, though cytokines are meant to act on a paracrine fashion, some cytokines exert a systemic reaction. Collectively, we call it an acute phase response. Everything is called an acute phase response. That's all, right? Even if inflammation is localized, but cytokines sometimes, few of them, not all, cytokines, few of them will exert a response far away from the site or exert a systemic reaction. These systemic reaction in collection, we call it an acute phase response. The next word I'm going to tell it for you, don't put in the exam paper. Acute phase response can be seen in both acute as well as chronic inflammation. Fine. Yes, Subhajit, the inflammatory bowel disease, one of the examples is Crohn's disease. Crohn's will have non-necrotizing granuloma only. Okay, perfect, done. So now, what are the systemic phase response? What all is required? One is talk about acute phase reactants by default. The second and the most important thing is fever, right? So first thing I'm going to talk is about fever. Fever, the most important reason for fever is there are three primary cytokines which are involved in systemic response or the acute phase reaction, which is interleukin 1, interleukin 6, tumor necrosis factor, which primarily acts on the liver to alter the protein levels. That's how they act, right? But these three cytokines are very, very important for the acute phase reaction. Do write them, right? First is fever. Fever is nothing but increase in body temperature of 1 to 4 degrees centigrade, right? More than 105, very, very, very unlikely. This is one of the commonest systemic response, right? It's increase in their body temperature. The reason of fever is very simple. Fever is protective, fever is symptom, fever is protective so that the organisms don't grow much, that's all. Here, how does fever happen? It can be due to pyrogens. Pyrogens can be both exogenous and endogenous. Bacterial lipopolysaccharide itself is a pyrogen. It can increase the blood body temperature, right? So it happens due to pyrogens. The pyrogens can be exogenous due to your lipopolysaccharide of the cell wall, the bacteria. Pyrogens can be endogenous as well. Generally, when you talk about endogenous pyrogen, we talk about prostaglandins. I am not denying that. Prostaglandin, yes. But even interleukin 1 and TNF are also pyrogens. They also help in producing prostaglandins, right? Your interleukin 1, your tumor necrosis factor. Along with that, the most important is prostaglandin E2. So these pyrogens go and alter your hypothalamic set point. If it alters a hypothalamic temperature set point, by default, I'm going to end up in having a fever, right? Slightly increased body temperature, which is nothing but fever, right? Once I have that, that's for the first systemic response for me. Rest every systemic response is based on few proteins called as an acute phase reactant. This can elevate or can reduce, right? So in acute phase reactants or acute phase proteins, just write a word about that before. Acute phase proteins or acute phase reactants. Fine. Okay, it's acute phase proteins, acute phase reactants, which is nothing but proteins or substances which either increase or reduce in response to inflammation. It can be both, but the goal is same, has to support inflammation in some point. That's how it is, fine. Negative acute phase protein, it reduces in response to inflammation. Simple things to remember, never forget albumin. If albumin is reduced in the body, my body cells can also not survive. Bacteria can also not survive. They also require protein, right? Then transthyretin or transthyroglobulin, right? That also will reduce in response to inflammation. These are negative acute phase reactants, right? Ceruloplasmin can, right? Okay. Now let's go to positive acute phase reactants. These are the one which increases in response to inflammation. These are more important than my albumin or a transthyretin. Those are negative, right? First example is elevation of fibrinogen. The elevation of fibrinogen is going to directly correlate to increase in the ESR during inflammation, because fibrinogen neutralizes the zeta potential, increases the sedimentation rate. That's first. Second, HSCRP, don't just write CRP, highly sensitive CRP, which is very, very essential for monitoring inflammation. In real life, we use them to see whether the inflammation is more or inflammation is less. Important, right? Third, ferritin, again, very, very important. The serum ferritin for same monitoring inflammation is important. Next, we have something called serum amyloid A protein or serum A protein. That also is fine. Serum amyloid A protein. This was related to amyloidosis. In the immunology chapter, we read about amyloidosis, where it will increase in response to inflammation. Again, all of these are due to your interleukin 1, interleukin 6, and your tumor necrosis factor. Those are the ones which is going to take care of all these things, right? Not just that, the newer edition of Robbins also has thrombopoietin. Thrombopoietin levels also will increase in response to inflammation, which might increase the platelet counts. Fine? Got it? This is about acute phase reactants. There's one more thing about systemic phase of inflammation which you have to write. Systemic response is not just due to fever or proteins. Even your changes in the bloods, that also is important, right? Even the blood related changes also is systemic. You will have leukocytosis, elevated WBC count. Based on what infection it is, it can either have neutrophilia. When it's neutrophilia, I think that most likely it's a bacterial infection, right? If it's eosinophilia, I think of an parasitic infection, right? So based on what it is, my WBC count will alter. If it's viral infection, which also sometimes might be acute, I think of an lymphocytosis, viral or mycobacterial, right? Second most important thing, do mention it if it's coming as a Y mark. There are sometimes I can have a very high amount of WBC count. Extremely rare conditions, right? When you have an extremely high elevated WBC count, we call it leukemoid reaction. Leukemoid reaction is leukemia-like reaction. So why do we call it leukemoid reaction? It's seen especially in sepsis-like conditions where it's not just the elevated WBC count, it's the elevated WBC count plus I have neutrophilic left shift, which means I'll have precursors of neutrophils. So when I have neutrophilic left shift or precursors of neutrophils, it's going to mimic chronic myeloid leukemia. That is the reason we need to know about that, right? Right? Okay. That happens, which is close differential diagnosis of chronic myeloid leukemia. We'll read why close differential diagnosis when we come to hematology, right? So systemic response, tell what is systemic response. Never forget fever. Talk about acute phase protein, both positive and negative, and talk about your thrombopoietins and talk about the blood level changes also, and maybe end with leukemoid reaction. That's enough, right? The last of today is about wound healing. Acute inflammation, chronic inflammation, wound healing, if it's sorted, most of the second chapter is sorted except for only one guy, which is inflammatory mediators. That I'm not going because it's purely a theoretical topic. I'm sure you know that better than me, fine? Wound healing, a short note along with factors. Sometimes just the factors which alter wound healing can be asked as a short note. When it's about factors, yes, Subhajit, when it's about factors affecting wound healing, I want you to explain wound healing first and then talk about your factors which promote, factors which delay wound healing, and little bit in an elaborate fashion. Why? We'll talk about that. If it's together along with the process of wound healing, I don't want why there. Just write, anemia causes wound healing, diabetes causes wound healing, that's enough. If it's only factors, explain why. Whenever I say factors which modify wound healing, also write a note on abnormal wound healing, which is hypertrophic scar and keloid. It is not separate, it goes hand in hand because that also is a modification of wound healing, right? Okay. Now, wound healing, we have two types of wound healing. There are actually three types. When you go to surgery, you will talk about tertiary intention also. For now, two types is more than enough for me. Fine. Okay. So, wound healing primary intention, which is a very, very, very clean cut scar. Okay. With no or minimal infection, with no or minimal tissue loss. If tissue is lost, secondary. If infection is there, secondary. Secondary infection, it's not a clean, it's a contaminated wound. Okay, it's a contaminated wound, plus it'll always have infection. Might have infection, that's what contaminated, right? And or tissue loss. Tissue loss also is, if it's significant, it won't heal by primary intention. Both primary and secondary intention, the steps of wound healing is the same. I'm just going to quickly go through the steps alone. The only difference is the duration of the steps will change. Primary intention healing might happen in 7 days. Secondary intention might take 14, 15 to 21 days. Little bit more because of the tissue loss being there, right? So when we talk about the wound healing timeline, right? The first, the steps of wound healing. If possible, again, draw a table. Table gives a little bit of more refined information. Left hand side, talk about the steps. Right hand side, put the timeline. So that they'll know 0 days, 1 day, 3rd day, 5th day. The person knows what they are writing. That gives an examiner a pseudo confidence that yes, whatever written inside also will be right. I hope the written inside also is right, right? So first step is, which is immediately after the wound, there'll be bleeding. Any wound will bleed plus clot formation. The clot formation with respect to wound, we use the term scab. Okay. So the timeline is almost immediate. Okay. It's immediate. 2 to 5 minutes it takes to form a clot. You know that, right? It's an immediate reaction. Why there is a scab required for me? Scab is the base for wound healing. It's very, very important for me. Without scab, I don't have a base. It's a scaffold. Okay. Zach Ryder, significance of knowing primary and secondary. Perfect. Let's say I am doing a surgery. Surgery for a person who is having a normal, simple appendicitis. I will know, okay, it's a simple appendicitis, not much contaminated. The wound will heal around 8th day. I will remove the suture around 8th day, or I will change the dressing around 8th day. Very bad trauma or a stab injury, that also requiring a surgery. Stab may, there will be foreign organisms entering inside. So the wound healing will be delayed. I might have lost some tissue. So the post-operative care will definitely delay and it will differ, right? That's the reason I have to know about primary and secondary wound healing. Clear? Done? Okay, let's go to this. Fine. So first is bleeding scab formation, which is almost always immediate, right? Second is neutrophils entering the space. Okay. Neutrophils enter, and the goal of neutrophil is to remove any foreign bacteria, any foreign organism which is there at the site of wound. It will be there for 24 hours. Like usual, within 24 hours, neutrophil should do his job and get out of the place. That's the purpose of neutrophils, right? Once neutrophils is done, who will enter? Macrophages. In macrophages, I have two roles for macrophages. So the timeline is not limited. I have a little bit longer timeline. First day, this will go. Around third day, it starts. Till fifth day, I'll have macrophages, right? So macrophages, initial, normal macrophage's goal is to remove debris and the overlying neutrophil. Okay. Then I have the M2 activated macrophage. That also will happen the same place only. This releases anti-inflammatory, which has to stop the inflammation, and also it releases growth factors of VEGF, FGF beta, which helps in the next step, and also TGF beta, which also helps in the next step, right? TGF beta is going to attract fibroblast, and VEGF, FGF beta is going to increase blood vessels. There are two things which happens, and the timeline is around 3 to 5 days. Okay, it differs. Again, body response also differs. Around 3 to 5 days. This is what maximum will be there, right? Around fifth day onwards, maybe starting of, we'll put like around starting of 3 only. We'll have the next stage, which is granulation tissue. It's not granuloma, it is granulation tissue. There's nothing but it's a hallmark of healing tissue. When I see this, I know that healing has happened properly. It's a hallmark of healing tissue, right? In granulation tissue, what we have is two things. One, it's a red color tissue, very bright red in color grossly. The reason for bright red color, microscopy will have neovascularization. Whatever happened due to the VEGF, FGF beta is happening here, and also I'll have collagen. The most important thing is I'll have collagen type 3. This will be around 5th day onwards. Third day onwards, you'll have third day is the maximum timeline for macrophages. We'll keep it as third day is the maximum time for macrophages, plus or minus 1. Fifth day is for your granulation tissue, plus or minus 1. Fine. Next, last but not the least, last is a scar tissue. Scar tissue will happen. Scar tissue is around 7th day. It's easy to remember, immediate 1, 3, 5, 7. That's why I can move the timeline such that so that you won't have a difficulty in memorizing the timeline, right? Scar tissue, it's primarily based on collagen type 1 and not type 4. Type 3 will change to type 1 collagen, and obviously the blood vessels which is there in granulation tissue will slowly disappear. That is scar, and scar is permanent. After scar is formed, the scar will undergo remodeling. It remodels for up to 3 months. Like any other collagen one, like bone, slowly removed, laid back, slowly removed, laid back. That's what happens. That's the exact timeline of wound healing. If it's second intention, maybe it'll take some more time. I might have necrosis for 3 days. I might have macrophages for 4 to 8 days. I might have your granulation tissue around 10 to 14 days. I might have a scar around after 2 weeks. The only thing is timeline changes, rest everything will be the same, right? And there are two abnormalities in wound healing, which is hypertrophic scar and keloid. Both are abnormal wound healing or abnormal scarring. Fine. Hypertrophic scar, there is no racial predisposition here. This is more common in Asians and Africans. It's more common in people in India, keloid, right? Hypertrophic scar is something which is almost always asymptomatic. They won't have any symptom. It's an ugly looking scar, that's all. It is not symptomatic. Here, yes, it can be asymptomatic, or it can itch, or it can pain. Keloids can itch or have a pain. Sometimes it can be asymptomatic as well, right? So hypertrophic scar is self-limiting, which means it does not have required treatment. Reassure the patient. 7 days, it will automatically become normal. Keloid is not self-limiting. Keloid is permanent. It will remain for a very, very long time. Fine. On the other hand, how do I differentiate? Differentiation is based on clinical examination. If the scar does not cross the wound margin, okay, the scar doesn't cross wound margin, that is hypertrophic scar. If the scar crosses wound margin, that is keloid. Okay, this is very, very important, and keloid needs treatment, which is intralesional steroids. I need to give steroids in the lesion. I have to inject steroids in the lesion. That's a treatment for keloid, right? So we know about the factors affecting wound healing and the two abnormal wound healing. We look at the factors affecting wound healing very soon, right? There's a gist of wound healing. So what all factors can affect wound healing? If we randomly ask, many of you will say that these are factors which we know: nutritional deficiencies, your angiogenesis, your infection. There are multiple things which can affect or alter wound healing, right? So if factors affecting wound healing alone is asked as a question, as a 5 mark, first try to separate them. I have localized factors, I have systemic factors. Both are important, right? It's factors, divide them into, yes, there are localized factors which can affect wound healing, and there are systemic factors which affect wound healing. Anemia is not a problem of the tissue, it's a problem of the person. It's a systemic factor. Infection in the site, local factor. Diabetes, systemic factor, right? So I can differentiate that, right? In local factors, infection at that site definitely will delay the wound healing, right? Any foreign body, someone falls down in an accident, sand and dust is there in the wound healing will not be proper. By default will not be proper, right? Again, a local factor. Movement at the site, micro movement or extremely movement at wound site. Movement at wound site is predominantly for bone fractures, right? Okay, it's fine, Zach Ryder. I also have keloid. Don't worry, I fell down, I have keloid. Keloid formation is pretty common in India. Unless it's disfiguring or painful, you want to treat, get it treated. It won't cause any long-term problem, right? If there's a fracture, I'll immobilize. If it keeps on moving, I'll have a problem. At the same time, I have a trauma around elbow. You keep on moving, I'll have a problem, right? This also is a local factor. It will definitely affect the wound healing, right? It will affect the wound healing by default. There's a mechanical force, that's it, right? Next, the simplest one is the type and the extent of injury. Though it's very, very variable, but that also I can add on to it. It's a local one, right? So if the injury is deep, it'll take some more time. That's my primary intention and the secondary intention by default, right? It can also have, right? Then systemic factors. Systemic factors, the biggest thing is nutritional status. Under nutrition, I can have multiple. Just anemia. Patient is anemic, not having enough blood supply. Wound healing will be delayed. Patient has vitamin C deficiency. The reason is we'll have less collagen formation. Wound healing will be delayed. Scurvy, one of the classical examples. Zinc deficiency will have delay in epithelial wound healing. Acrodermatitis enteropathica, right? Zinc deficiency will cause reduced epithelial regeneration. That's an important cause. I can add multiple micronutrients like cobalt can cause a problem, right? But these three are something which I should not miss, right? Next, diabetes. Diabetes causes primarily vasculopathy. It also causes reduced inflammation, but vasculopathy is a bigger concern for me. Whatever neoangiogenics produced in granulation tissue, they are damaged vessels, cannot heal properly. That's the important thing. Multiple reasons, but one of the important thing is vasculopathy, right? Next, drugs. In drugs, one of the important drugs is steroids. Steroids is anti-inflammatory. Na? If I have something anti-inflammatory, my wound will not heal. That's predetermined, right? I give anti-inflammatory, I will not have proper neutrophil, proper macrophages, fibroblasts will not happen properly, TGF beta will not come properly, right? All this will result in wound healing delay. Steroids is one of the important reasons for wound healing due to drugs, right? So it's just a tiny table. So 5 mark, just write them. If it's a long answer, maybe elaborate why it causes. See, ultimately in an exam, first internal might look very simple, few chapters. University exam will look very big. At that time, if I have solid 8-7 points for a 5 mark question, you can solve it. 10-15 points for an essay, that's more than enough. The advantage for you is essay is subdivided, which means if it's a question on acute inflammation, steps, I know 2 points. Mediators, I know few. Diseases, I know few. That's enough. So for every topic, you need to know solid 5-6 points. That's more than enough for you to write an exam and get a superb mark. Fine. Okay. That's about the factors which cause wound healing. And an example of keloid after an ear prick. And what happens in keloid in microscope is there's abundance amount of collagen deposit. Dense collagen deposit is what is seen in keloid formation, right? Okay. That's about inflammation wound healing chapter. The only thing which are not much emphasis is your inflammatory mediators. That I'll go and have a look. Tomorrow we'll try to cover hemodynamics and shock, where my primary focus will be on the shock, little bit of infarction, and also about your edema. Yes, I'll talk about it, but more about infarction, embolism, and shock is where I will be more concentrating because exam questions comes there. Fine. Great, Subhajit. Just go back and just revise once again about the inflammatory mediators. That should end the topic. Fine. See you guys tomorrow. See you at 4 p.m. tomorrow. Till then, bye.